Yes, sir.
So chronic smoker posted for that. So again, I'm saying the heading into challenges in this case are PO is an inflammatory occlusive vascular disease. It is uh, may be present in the upper or lower extremity. And another challenge is these people are chronic smokers. So all the ill effects of smoking, like this may be the in discussion that can also be asked in the examination. So you must know all about smoking, the effects of smoking on CVA, the RS, and the autonomic nervous system. Now the discussion again should include history, duration of PAO and its progress, smoking history, number of fat years, treatment tried if any, like medical treatment or clock, general examination of the patient, plus local examination of any lesion, investigation, risk stratification, optimization, intra-op management, GA versus RA. So these are the series of discussion that we have to take. Now, what is TAO? It is a non-arteriosclerotic segmental inflammatory occlusive vasculitis. It can affect both the arteries and veins, between small and medium size. Signs and symptoms: abnormal sensation and skin color, coolness. The periphery becomes always cold because of the lack of blood supply and there is no temperature supply. Dry skin, decreased sweating, hair loss and slow hair growth, muscle atrophy, migratory superficial phlebitis. One area will be painful and then the next area becomes painful. And intermittent claudication while walking, which will ultimately goes to produce even rest pain in rest. And patients may develop ulcers and gangrene. And when you palpate, there are weak or absent pulses. And the picture may be something like this with affected areas tending to become ulcers. Pathophysiology is still unclear. However, disease consists of an acute inflammatory phase followed by chronic proliferative phase. So, if you see microscopically, these are all the changes. They classify here into acute phase, subacute, and chronic phase. And the neutrophils and giant cells occlude the vessels but spare the wall. So that is why it is non-arteriosclerotic. Vessel wall is not properly damaged. And in subacute, progressive organization of the thrombus takes place. And in chronic case, inflammation is no longer present and organized thrombus and vascular fibrosis remains. And it is the vascular fibrosis which determines the ultimate prognosis. And the ischemia features, they range from intermittent claudication to cyanosis, Raynaud phenomena or paresthesia, rest pain, phlebitis migrans, all can manifest. And there is a criteria called Chionoyo criteria for diagnosing PAO. And there are 5 things that have taken into consideration. One is smoking history. Usually the onset is below 50 years and affects intrapopliteal vessels by occlusion, upper extremity involvement, the form of phlebitis migrans, and the absence of atherosclerotic risk factors other than smoking, like hyperlipidemia, diabetes, are all not present. So these 5 things are considered are what is called the Chionoyo criteria. And how does smoking cause TAO? Smoke can directly sensitize, but nicotine can act as a hapten. It binds to what is called a histone or a DNA in cells, changes the composition of its own tissues, lead to production of autoantibodies. And smoking can also reduce the oxygenation of arterial blood. And how does smoking cause oxygen reduction? What is the mechanism?
Polycythemia and decreased oxygen carrying capacity.
No, polycythemia is a compensatory phenomena to carry more oxygen. But how first the first
Carbon
case,
monoxide.
the carbon monoxide in the smoke that has got more affinity than oxygen. So it prevents oxygen getting bound to the hemoglobin. And
Yes.
that is how deoxygenation happens. But will it be evident in pulse oximeter?
No, sir.
Why?
No, sir.
Why you cannot find out the hypoxemia in the presence of carbon monoxide by pulse oximetry?
Wavelength, oxygen.
Wavelengths are more or less similar. So pulse oximeter may show a normal value, but patient will actually
Have
be hypoxemic. So how do you detect whether it is
co-oximetric value. Coaximetry.
Co-oximetry from ABG.
co-oximetry or blood oxygen ABG analysis? That only will tell you whether the real state of oxygenation. Okay, and
Sir.
so the smoking reduces oxygen in arterial blood by more carbon monoxide being inhaled. It increases viscosity, slow down the blood flow, constrict the blood vessels. This phenomena factors occurrence in developmental vasculitis. So this is the pathophysiology of smoking causing PAO. And differential diagnosis can be scleroderma, lupus disorders, clotting disorders, and diabetes mellitus. Anti-brachial index is usually done for assessing the blood flow. It's a ratio between the systolic BP at the ankle divided by systolic BP at the arm. So BP at the lower limb should be higher than the arm level. So normal value is more than 1. Whereas in patients who have less blood flow, the ankle BP will be low and the arm BP will be high. So the value will get reversed. So that is an important method, clinical method of diagnosing them. And photoplethysmography, which is something like your pulse oximetry, so that also can be used. So that will also help you to find out the reduction in blood flow. And the Lumbar dependency test is a physical examination used to assess the peripheral blood flow. Have you read about this? How to do this test? Lumbar dependency test. No. You ask the patient to elevate both the lower limbs. Okay. And then up for about 60 degrees. Then ask him to keep it like that for 1 minute. Now already the blood flow is low in cases of PAO. So when you elevate it against gravity, further reduction in blood flow will happen and the sole of the foot will become pink or pale.
Pale.
It will become paler because there is a reduction in blood
Reduction
flow.
in blood flow.
And once you bring the foot below the table level and drag them down, suddenly excess flow will come and the whole limb will become engorged and will become flushed. So you can see this elevated foot becomes very pale, pallor happens, venous drainage has happened, so veins are all collapsed. Once you drop the foot, there is the dependent foot becomes highly vascular, lumbar, and veins become dilated. So this is a very simple test by which you can identify the presence of PAO, which is called Lumbar dependency test or physical examination. And the treatment that you can do for PAO are nicotine replacement for those who cannot stop or avoid smoking. You can it's like your de-addiction. You can do that nasal spray of nicotine 80 to 40 doses per day in a drug called bupropion 100 milligram, nasal lotion of nicotine. All these things are anti-nicotine replacement drug therapy. Then antiplatelet drug therapy like 79 to 350 milligrams of aspirin, clopidogrel, clopidine, of course, is gone out of vogue. Vasodilator drugs like cilastrozole, calcium antagonists like your nicotine, and antihistamines like thimerosine and vitamin E. All these things have been tried. And the latest is stem cell therapy, which is also tried in PAO treatment for neurovascular formation. Okay, so
Yes, sir.
these are all the things. And of course, the Complications are muscle weakness, atrophy, sensory motor impairment, ulceration, and gangrene. Interventions you can do or sympathectomy, which can be clinical, surgical, endarterectomy, stenting has been tried, bypass grafting has been tried. Ultimately, amputation gives mainly from pain relief. Sometimes patients have very intense pain, which makes them get addicted to narcotics and alcohol. So they become abusive patients. So in that patients, amputation gives pain relief from the vasospastic pain. And differential spinal assessment response to sympathectomy derived from the concept of different levels of block hyperbaric local anesthesias are administered. And so we can inject a very low concentration local anesthetic subarachnoid phase and measure the skin temperature before and after the block. And both DA and RA can be a technique for after assessing the serious and cessation of smoking. These are the two things that we take into we are planning for DA. And the constituents of cigarette and cigarette smoke, they ask you all that. It contains carbon monoxide, nicotine, tar, polycyclic hydrocarbons, nitrosamines, etc. And the clinical effects of cigarette smoking, cardiovascular, can lead to coronary artery disease, cardiac arrhythmias, or even subarachnoid hemorrhage. Respiratory can produce COPD, reactive airway, chronic smoker's cough, frequent breath holding because of coughing, laryngospasm, increased fluid secretion and retention, risk of developing pneumonia. Gastrointestinal relaxation of the lower gastroesophageal sphincter leading to GERD. Reduced rate of post-op nausea and vomiting. This is the only advantage of reduced smoking. Reduce the rate of post-op nausea and vomiting. Other system, diminished immune function resulting in poor wound healing, abnormal bone metabolism causing delayed fracture healing. So with that, the discussion of these two topics are over. We have time for some asking.
Yes, sir.
Yes, sir.